is, thank you, Alba. So it's his bio is voluminous and his CV is even bigger. But I will tell you how I know Mr. Generally. He is really a leader in when he first came was a Six Sigma lean methodology. At the same time, the same time I was doing the masters, and you were one of the
Mhm.
instructors in that course. And then along with that, just developing programs to help leadership and frontline staff. Uh, and then, of course, COVID occurred, and just he was transformational in how we took COVID in stride, and the system worked so well together. Uh, Diversity, equity, inclusion leader, and also a leader in patient experience, improving the patient experience. And I've listened to some of Mr. Janelli's talk. So now I'll read from his bio, but with all due apologies, Mr. Janelli, I will truncate it so that
Yeah,
I have
I
more.
was just going to say, you can just make it available to everybody. You don't have to read it, really. But it's up to you. Whatever you feel is best.
Right. So just a little bit of context. I just mentioned in a few words my experiences with your leadership. And in the context of people who don't know, Mr. Ginelli is the Chief Transformation Officer of the health system, and he's the president of Mount Sinai Morningside. So he's a leader of one of the 8 hospitals and led the hospital's response during the COVID-19 pandemic, introduced lean daily management system, driven improvements in patient experience, quality, and safety, shepherded a transformative capital improvement program, and worked with the School of Medicine leadership to grow clinical programs. Under his leadership, Mount Sinai Morningside earned a 3rd place designation in the National Innovative Award Program organized by Editors of Healthcare Innovations, which is a trade publication. And he was also recognized as one of the leaders in inspiring chief transformation. I mean, he's inspirational chief transformation officer in healthcare, and was acknowledged by Crane's New York Business as a notable healthcare leader. So this is my best attempt at truncating his very broad knowledge base, his very broad experiential base, and his very stellar leadership roles. Please, it's all yours, Art. Go ahead.
Oh, thank you so much. And let me just share my screen. Here we go. All right, perfect. So that you guys can see my talk. Hold on, there we are. So let me just say a few words. So first, I want to thank the Institute for the really the generous invitation to address you today. As I said, I'm not, as I said earlier, I'm not a physician, so I'm always really humbled when I'm asked to speak at grand rounds. And I take that very seriously. It's really a privilege, and I'm really honored to be here. One other accolade that's not my accolade, but I want to put it out there for to plug Mount Sinai Morningside. Mount Sinai Morningside is listed by Newsweek magazine as 29th in the world for being amongst the best smart hospitals anywhere in the globe. 29th. Mount Sinai Hospital is 5th, which is an unbelievable achievement. But the fact that we're in the top 30, and that's happened twice in 2 years in a row, is really, I think, indicative not only of the quality and the capacity of the IT infrastructure that we built there, but how we use the data. And specifically to try to use data, real-time data out of Epic to drive operational decision making, and increasingly to connect our data systems and our command center with the use of predictive modeling again, really driven by the data scientists at the Icahn School and at Mount Sinai. But we want to be active users of the of predictive modeling. So, that I'm really proud of that, because I think it reflects a lot of very creative work done by folks at the system level and also at Mount Sinai at Morningside. And it's always fun to see, little old Mount Sinai Morningside amongst these elite global hospitals. Again, I'm really quite proud of that. So, what I thought I would talk about today, and I'm going to try to be mindful of time so that I leave time for question and answer. What I wanted to do is talk about some work that I've been partnering to do throughout the health system and thinking about, and that is how to lead hospitals and health systems in the aftermath of COVID. Because the challenges that we're facing in the aftermath of COVID are in some ways unprecedented, and it's putting interesting demands on leadership in ways that I've not seen in my career, and I don't know anyone of my colleagues here or elsewhere in healthcare who's seen that either. So, I circulated the learning objectives previously. We don't need to go into this. The presentation will guide us to answer those questions. But I like to set the stage with some quotes, and I use 3 quotes for this discussion. The first is attributed to Mike Tyson. I've never been able to figure out if he actually said this or not, but if he did, he's brilliant. And that is that everybody has a plan until they get punched in the mouth. And I like that quote because, it speaks to what we're dealing with now as a health system and as an industry. And that is, we were punched in the mouth by COVID, and it's really changed and upended our expectations and what we understood about the delivery system and what we understood about the evolution of healthcare. Things have changed. So we've had our punch in the mouth, and old plans I think need to be set aside and new ones need to be developed. I'm a big Star Trek fan, and I've always found this quote to be inspiring. It's simple but powerful. That is that there are always possibilities. Meaning, in the end, even if things are looking really challenging and you feel like you're not able to advance where you want to advance to organizationally, you have to just have faith that there are possibilities for ways out and possibilities for success. I'm a believer in that. I believe that all my career, and I believe that now. And then last, a more conventional quote, but important nevertheless, from the CEO of YouTube: rarely are opportunities presented to you in a perfect way in a nice little box with yellow bow on top and say, here, open it, it's perfect, you'll love it. Opportunities, the good ones, are messy, confusing, and hard to recognize. They're risky and they challenge you. And I use this quote because I think it's important to understand that right now we're severely challenged, but when you're severely challenged, that's where there are opportunities, but those opportunities are sometimes masked by the challenges that we face. So we have to understand that about our reality in order to be able to see those opportunities, despite the challenges that we combat each and every day. So, the pandemic was an acute and unprecedented crisis, which fundamentally and profoundly disrupted the delivery of healthcare in the United States. I would make an argument that sometimes when we think about crisis, we don't properly analyze the crisis. We think about the crisis in its acute phase, but I would argue that you have to think about the acute part of the crisis, and then you have to think about the aftermath. It has different defining characteristics than the acute phase, and I'll go into that. So this is my typology, so it certainly can be argued with. But I would argue that this distinction is really important for understanding what we're dealing with now and how our challenges have evolved. We all lived through the acute phase of the crisis. It was time-bound, it was dangerous. I tell this story. I forget which unit it was in my hospital, but I remember rounding the day where we were flipping over, and this particular unit was now going to be an endemic, and it was all COVID. And I remember looking around, this is early, so this was March of 2020. And I remember looking around at the huddle on the unit and being struck by the fact, honestly, that almost everybody there was probably 15 to 25 years younger than I was. And, you know, it's sort of a striking realization that you're asking very young people to go off and do something, the result of which you didn't know. Like at that point in time, we had no idea what the outcomes were going to be. We had no idea of what kind of harm we were potentially asking our staff to expose themselves to. That's had a profound effect on me, and it's something that visual, that moment is one of those moments in my career that I remember to the day I died. Crisis is uncharted and it's an immediate threat, right? And we lived through this. But what we're living through now is not the crisis itself, it's the aftermath. All right. And the aftermath may go on for years, for all any of us know. And it's almost like I would characterize the aftermath of the crisis almost as if we were living with a chronic disease, right? It's a disease, you can't shake the disease, you can't get rid of the disease, you manage the disease as best you can, right? So it's a chronic challenge as opposed to an acute challenge. It's ongoing as opposed to being time-bound. It's damaging in a way that the original crisis wasn't, because because of how long it's enduring and how differently it's shaping our reality. It is building the new normal. I know that's sort of a euphemism at this point, but the reality is it is creating a new normal that we have to understand and work through. And it's a sustained challenge as opposed to an immediate threat. So I like to think about it in these two components, because I think it really does help us to understand what we as leaders have to grapple with. Now, the environment for hospitals has been shaped by the aftermath. Some of these dynamics that I list here pre-existed and have been exacerbated by the aftermath of the crisis. Some are new and a function of the aftermath of the crisis. So, we've got cost pressure here as a hospital system, inflation and disruptions in the supply chain as example, wage increase, the cost of traveling nurses as an example. Excess days, this is one that people don't focus on, but it's really important, right? If you've noticed, the length of stay across the Mount Sinai health system has gone up significantly. At Mount Sinai Morningside, it's gone up more than a day. Pre-pandemic, every hospital averaged beyond more than 1 day of excess days per discharge, meaning that those excess days are days that you essentially are not reimbursed by your managed care. So if you think about it, if we've now added another day, that's another excess day. And every one of those excess days for any hospital across the system are unreimbursed by the payers. So that extra day is a massive burden because it brings in decidedly no revenue. Yet the work goes on, right? These patients are sick, they're older, they're more complex, but because the length of stay has been extended for a whole host of reasons, right? Very difficult to discharge to nursing homes because they lack staff, very difficult to discharge to home care because there's insufficient staff, other challenges that we're facing, all of those things coming together basically mean that hospitals are incurring a lot of extra work for literally no additional money, which is an unsustainable business model. Right, we have more patients covered by government insurance, and because they're covered by government insurance, we get reimbursed less. Purchasers are demanding more and more care for lower and lower cost. We are experiencing unprecedented challenges in recruitment and retention. I was looking at a data point for our hospital earlier this week when we did a town hall for our nurses. We've hired 271 nurses at Mount Sinai Morningside in 2022. We only have about 700 nurses in the entirety, both on the ambulatory side and on the acute care side. So, more than 40% of our nurses have turned over in just 1 year. All right, that's happening throughout the health system. That's happening throughout the country, and that kind of turnover leads to real challenges. For what kind of wellness support can we provide? It leads to burnout for the staff that's here. We're seeing increased workplace violence, and with the turnover that we're observing. It's less and less institutional memory. There's so many people now that work here that don't know what our health system was like before the pandemic because they didn't work here before the pandemic. And then we have external threats that, again, the COVID aftermath hasn't generated so much as it's exacerbated. Big corporations, private equity, and venture capital all looking to try to drive changes to the delivery system and finance them with lots of money that create real challenges for hospitals and health systems like ours to be able to compete. And this is just a slide to show what all of this has conspired to do over the last year as it relates to hospitals. Typically, in a typical year, 30% of hospitals across the country will lose money. This year, more than half of hospitals across the country will lose money. And as you can see, the average hospital had a negative operating margin each month of the year through September, and I expect that to continue through the end of the year. That creates, that margin pressure creates an unsustainable context unless we really fundamentally change how we do our work. So what I want to talk a little bit about now is I want to shift gears. That's context, right? So I want to talk a little bit about, how have we thought differently about leadership in the wake of the pandemic? Now, as Dr. Gidwani had noted earlier, right? I wear a lot of hats in the health system. So one of the hats that I have, or a couple of hats that I have in my role as Chief Transformation Officer, I do a lot of work in cultural transformation, not so much in like digital transformation, but really in like cultural transformation. And so working with Diana Adams and our System Learning Council, and also working with the team that's driving the roadmap for action for equity and anti-racism at the Mount Sinai Health System. We're looking to try to build a post-pandemic leadership model here in the Mount Sinai Health System, a model that we would want embedded wherever we teach leadership throughout the health system, or wherever we hold leaders accountable throughout the health system, so that we have a common definition of what it means to be a leader here, what it means objectively, and what it means behaviorally in the health system. We've never really had that before, and we certainly didn't have a model that reflected some of our post-pandemic realities. So the elements of the Mount Sinai Health System leadership model that we're looking to try to build and pull together are four. One is anti-racism. Second is continuous improvement. 3 is transformation. 4 is well-being. So the idea is that we want to connect what it means to be an anti-racist leader, right? And if you look at the definition, an anti-racist leader invests in deep reflection, establishes an anti-racist mindset, models and upholds behaviors to instill equity, supports anti-racist practices, and embeds anti-racism structures throughout the organization. And they have a disruptive role in the organization because they hold a mirror to us and make sure that we make sure that we're accountable for looking at what we do through equity and anti-racist lenses. Continuous improvement, as Dr. Gidwani had noted, is something that's very dear to my heart, and it's something that's very important to me. We've established Mount Sinai Morningside as a lean hospital, and I've used my system title to help others to spread lean throughout the health system. And there are key components of the continuous improvement lean leader model, and I'm going to talk about them a little later on, that I think reflect the kinds of leaders that we want in our organization. Transformational leadership is sort of the standard model of leadership that we use. We use it principally in our applications for Magnet. And well-being centered leadership, Dr. Rip has educated us about the importance of this model. And there's a lot of overlap with the other models, but we felt it was important in the post-pandemic period to conspicuously and overtly connect leadership to well-being, to connect leadership to anti-racism, and connect leadership to transformation and continuous improvement. So, our model is going to be, starting to learn and empower others and embrace change to further advance equity and improve the well-being of staff, patients, and the organization. And the goal is for the Mount Sinai Health System leader to embrace anti-racism, create a collaborative, respectful, and supportive environment, and deliberately and constructively disrupt the status quo. Our leaders find new solutions to transform traditional models, empower our workforce to thrive, and enable everyone to do their jobs efficiently and effectively in a workplace built on compassion, trust, inclusivity, and equity for all. Now, that's obviously aspirational, but we wanted to set the targets for our leadership aspirations because we want to align our leaders across the organizations, in these directions, so that we're not teaching different approaches to leadership depending upon where you are in the organization. So now, on my own, for my team, all right, this isn't being, we're not spreading this across the health system, but I wanted to talk about how do we think, how do I think about leading in the context of the aftermath of the pandemic? And I would argue that this is I'm not a particularly great graphics person, so forgive me, but this is, essentially trying to capture, I think, key elements of the approach. It resides on a bedrock of cultural transformation. We need to connect daily management, improvement, and lean leadership, and all of that supports approaches at framing problems, executing solutions, communicating with staff, and supporting staff. All of that builds towards our new reality. There's a lot on this slide. You don't have to worry so much about this, but that slide that you see here is a slide that I use to try to describe how we do cultural transformation at Mount Sinai Morningside. So what I try to do at Mount Sinai Morningside is take lean as a vehicle, not just for continuous improvement, but not just for the elimination of waste, but for transforming how we think about the culture, right? And what we try to do at Morningside, and I would advise other people in leadership positions to think similarly, is how do you take culture, which tends to be intangible, and make it tangible? What are the ways you can press buttons within your organization to make things tangible? And so if you look at the left, for example, those are all ways where we think we can replicate our culture. When we recruit people, we can recruit with a lens to look at them through our mission and vision and values. When we onboard, we want to talk about who we are and what we believe in culturally and in terms of our values. When we communicate, we want to do that. Educate, reward, and recognize. When we had our Muhlenberg Awards, which is our annual awards reward and recognition ceremony yesterday, and every nomination, for the award needs to connect the awardee to the proposed awardee to the mission, vision, values of the organization. So you hear repeated how they exemplify our values, and that's the way you I think drive that throughout your organization. And I'm just going to make a point to go to the last box here, which is everyday greatness. So this comes from actually a conversation that Dr. Davis and I had. And I think it's important to for somebody like myself who's not a physician and not a research scientist to say this. I said to Dr. Davis, I said, I am amongst the proudest people imaginable, right, in this health system, for being here with the kinds of people that are here, like identifying, just amazing discoveries that are going to contribute to the science that's going to cure people. of cancer, of diabetes, of other conditions. I mean, it's extraordinary, right? And I said, I think that's fantastic. But I said, you know, equally important is that for most people who come through our doors, they don't necessarily need that amazing science. Some people do, but most people, they want to be treated like human beings. They want to be cared for as individuals, as if they were members of our family. They're scared and they're looking for support, you know, and they're looking for some protection, and they're looking for the comfort, and they're looking to be able to navigate through, you know, easily, seamlessly through a very, very complex system that they're not used to. And I said, that's the everyday work that we do, right? And there we have to be great. Everyone has to be great. Whether we're talking about me, or we're talking about our physicians, or whether we're talking about our nurses, or whether we're talking about our environmental services professionals, or whether we're talking about our food service professionals, our security guards, everybody needs to be great every day. And that's really got to be the culture. We need to match that against just the unbelievable work done scientifically in the Mount Sinai Health System. And that's kind of the way I try to think about cultural transformation. You know, when I talk about lean, the approach that lean takes, again, it's not just a way of improving processes, it's not just a way of eliminating waste, it's a way of thinking about the relationship between frontline staff and managers. So what lean says essentially is to flip the script, and where managers, where leaders coach frontline staff, where you recognize that wisdom resides with the people that do the work, not in the boardroom, not with the executives. That, you know, it's respectful to go and see the work that's being done. Don't overload your system with metrics. Focus on key metrics that are going to move the dial towards the key outcomes that you need to see. Be obsessed with process, not just accountability. Accountability is important, but be obsessed with process too, because oftentimes it's not that an individual made a mistake, it's that we have a process that doesn't work, and we need to understand that. There needs to be freedom to fail. We need to be able to undertake experiments and have them not work out. I had we had a graduation for our bronze belt in lean, and one of the graduation speakers discussed an experiment that she undertook to reduce the ordering of magnesium tests in our emergency department, because they're over ordered by the literature would suggest by 80%. And the point here is not necessary, wasteful practice, you know, costs money. Her initial experiment didn't work, and that was her presentation at her capstone, was about how that experiment didn't work and what she was going to do next. I made a point of saying at that graduation that I was very proud of that moment, because I know when we first started, nobody would ever talk about when something didn't work. But I think it's important to talk about when things don't work, because that's the only way we learn, and that's the only way we get better. And we can't run away from that. We have to allow for the freedom to fail. We want to move away from firefighting. We want to move towards daily management, because what we want to do is create an environment where our calendars don't control us, but we control our calendars. Now, these next two slides, you know, the main things that I want to say here are there's some tools that you can bring in to your management here at Mount Sinai that, you know, we can borrow from political science, and you know, one is this notion of agenda setting, and one is this notion of Overton window. I'm just going to focus on the Overton window, because I think the point here to drive home is that, you know, if you think about things through this lens of the Overton window, what you can do is you can think about what's possible today, and you can look through that same lens a month from now, and what's possible may be very different. So, for example, right, you know, just yesterday in the United States Senate, by I think with a vote of 63 yeas, the Senate approved legislation that would protect interracial marriage and gay marriage. And if you think about it, if that vote were taken 5 years ago, it would never have passed, right? So what's possible now may have been radical and unthinkable just a few years ago, right? It's important to apply this lens because you may, you may discover that certain things are possible in a way that they weren't historically. And the window may or may not stay open for you to do that. All right. So I use an example, for instance, of the anti-racist efforts that we're undertaking here at Mount Sinai in the wake of the death of George Floyd. The window has stayed open here at Mount Sinai, and the work continues. All right. And it's very important that we take advantage of this window being open. If you're leading, you have to be sensitive to what is the window open to do, like what's possible and what's not possible. And does that window shift that brings things that weren't possible previously into possibility now? All right. And I would encourage people, particularly in leadership positions, to think that way, because, you know, time is short and windows of opportunity don't last. And it's important to have your ears to the ground and your antenna up to understand those dynamics. So when you're executing changes, in my view, you know, when you're leading, you want to tap an underlying culture of experimentation. Test ideas that maybe weren't possible pre-disruption, pre-pandemic. Fail fast, right? Experiment, see if it works, learn from it, move on. When you execute, one of the key ways to execute strategy and be successful is build in small wins. Small wins build credibility for the work that you're doing, and they make people feel better about their work environment. You know, I was doing a town hall once, and I'm talking about all these capital plans that we were doing, and you know, really trying to pump up the audience about where we were going to take Mount Sinai Morningside. And this young woman raises her hand and she says, you know, I'm listening to this and it's fantastic. But she says, I got to tell you, she's like, our office asked for a refrigerator to put our lunches in. And it's been like 4 months and we haven't gotten this refrigerator. So how are we supposed to believe you when you're out there talking about all these amazing plans that you have, if we can't get a refrigerator that we asked for in under 4 months? So I told I told her she made a fair point, and I told my team afterwards she's getting her refrigerator like ASAP, and sure enough, we were able to deliver that. But think about that. That's a small win that builds credibility for larger plans that you might have. And then you need to understand that strategy is not just about what you're going to do, but it's also about what you're not going to do. Too often here in the Mount Sinai Health System, you know, we just do everything, right? Everybody does everything. And the problem is when you do that is you're not acting strategically, and you're distributing your resources and you're burning people out. And so one of the things that we've got to really be focused on is what's critical. What are we doing for whom? And therefore, what are we not doing? So that we can deselect as well as select. You know, when you communicate, it's important to be visible and personal. You know, even if you're not a frontline worker, your visibility shows that you respect the frontline workers. You know, try to make individual connections with staff. Using stories to connect really helps. Respond directly to their emails when they send them, right? Use all channels for communication, recognizing that employees get information from a variety of different sources. So you can communicate verbally, you can communicate non-verbally, you can communicate, again, you know, informally, you can communicate informally, but your employees, you know, build a composite of you through those communications. Use all of the different channels, because that's how people in organizations gather their information. And then in terms of supporting staff, it's just important to listen, to be radically empathetic, put yourselves in the shoes of the staff in order to be able to anticipate needs. and recognition. You know, I was again at a nursing town hall the other day, and recognition was one of the things that was brought up as really being important. That people just want to be valued for the work that they do, and it's not too much, obviously, to do that. Okay, in the remaining time, I just want to move quickly through a discussion. Given our discussion about leadership writ large, and given our discussion of, you know, a model of leadership that can help you through difficult times, what are some of the big changes that we're likely to see in our delivery system? How can hospitals and health systems pivot from the pandemic and its aftermath to succeed in the context of whatever the emerging normal is? So I would make a few points. The first point I would make is that the pandemic really, I think, illuminated significant weaknesses in the government's ability to manage the complexities of healthcare delivery. You know, whether we were talking about understanding the capacity of the various hospitals in the state, as an example, being clear about the protocol for vaccines or for masking, et cetera. All of those issues, or having the resources stocked up in the event that we, you know, confronted a pandemic as we did. You know, the government fell short in a lot of ways, and it's clear that hospitals have to be prepared to be more self-sufficient for the next crisis. So we need to look at what we think the possible crises are, and make investments in hardening our institutions and ensuring that we have some level of self-sufficiency to protect our staff. But I think one of the bad things is that probably for the first time in the history of the United States, public health has become politicized, and that's going to affect us profoundly when we have the next pandemic or the next public health crisis, because there's a significant chunk of the country that now won't believe what our public health experts are telling them, and that's sad and that's dangerous. Hospitals, I think, given the financial pressures that we're under, hospitals really have to figure out how to organize their operations to take on more risk. You know, the movement to value-based payments has been discussed for years. I think it needs to be real. And if you think about it, during the pandemic, had we been taking more premium risks, we would not have had, you know, the major financial challenges that we did, that were only really eliminated by governmental relief. And the problem with governmental relief is you're dependent upon the vicissitudes of who's in charge. And, you know, if different people were in charge, the amount of relief that came to hospitals like ours, which was in the hundreds of millions of dollars, may not have been forthcoming. So, you know, we need to make sure that we protect ourselves, and moving more swiftly in the direction of value-based payments not only is a good thing in terms of aligning quality of care and our effort, but it's also a good thing, I think, in protecting us in the event of another set of exigent circumstances. You know, we talked a lot about equity, and we continue to talk a lot about equity, but in my view, there are limits to how far healthcare providers can go if, in the end, for the same set of services, providers are paid dramatically different amounts by the payers for the same services. So, you know, if Medicaid is going to pay only a fraction of what a commercial insurer is going to pay, at the end of the day, that is going to distort how healthcare is delivered. And we need to fix that. The problem in our country is that a single payer plan is virtually, I think it's not virtually, it is impossible to pass. So you need to look at other models of financing healthcare, and there are other models out there that are essentially all payer models that are used in Maryland and to a more limited degree in Vermont. They may not be the right ones, but at least they point in a direction that's worth exploring. And I think in New York, this is going to come to a head, because the reality is that New York has increased from $400 million to, I think, $2 billion, the amount of subsidies that it's providing to safety net hospitals across the state of New York. I mean, that can't continue. right? There needs to be another answer to these questions. Health systems must drive value for patients as they did during the pandemic. You know, I think what was interesting about the pandemic period was the fact that we were creative in coming up with ways to deliver value to our patients. We leveraged here at the Mount Sinai Health System the systemness of the system, right? We operated in a way that protected our outer borough hospitals by distributing patients, for example, across the system. Systemness, you know, can drive innovation and value, right? Rationalizing the distribution of clinical services, standardizing clinical protocols, rapid deployment of PDSA successes, in-source labor flow pools, internal teleconsultation, for example, which we have in a number of different service lines, low cost settings for low reimbursing procedures or surgeries, and using larger data sets to power predictive modeling. These are just some ways. The fact that we've come together as a system can transform the system going forward. The pandemic showed how hospital creativity is unleashed when regulatory hurdles are removed. You know, during the pandemic, we got to pretend like the regulation didn't matter, and you know, lo and behold, what happened is we got innovative, we got creative, we created ICU beds literally out of nothing, right? And you know, we want to harness that creativity, not stultify it under a bevy of outdated regulations. So I think we've got to be trying to unleash that creativity during good times so that we can build upon that during times of crisis. The pandemic underscored the importance of further improving access. We know that, you know, there were disparities in the health outcomes of some of the patients that we have that was clearly correlated to their ability to access care. One of the issues, though, that I've tried to pound the table about, you know, and I think I'm right, I could be wrong, but I think I'm right, is that as we move to telemedicine and telemedicine solutions for outpatient care, we're going to replicate the same inequities unless we think about it ahead of time. You know, do our patients have access to the computers? Do they have access to broadband? Do they, you know, these are real questions that we need to work through so that we don't simply, you know, photocopy the same inequities that we've had historically in a new way of accessing care. And leadership should continue with the frontline orientation, which the pandemic fostered. That's embedded in the type of model that we're trying to build here for the Mount Sinai Health System, where again, you know, recognizing that wisdom resides with the people that do the work, that they're closest to the work, and it's the job of people like myself, not to be coming up with solutions, but rather to be empowering people within the organization to come up with ways of improving the organization every day. And I think lean is an optimal leadership model for doing that kind of work. And here, just to conclude, here what I have is just what a successful health system might look like post-pandemic. It's going to be resilient and hardened. It's going to be digital, where you have an easy to access digital front door, easy to access, understand bills, and easy to obtain personal medical record. You don't have that quite yet. Efficient flow of patients, which is a big challenge right now that we're facing. Remember, you know, we've added about a day length of stay, so our patients are not efficiently flowing through our system, and that's work we have to do. Increasing standardization of clinical services, distributed centers of excellence, so that, you know, we get away from the model that every hospital has to do everything. Wide use of predictive modeling, culture oriented toward continuous improvement. Flipping the script on what leadership does versus frontline staff, moving ambulatory services to lower cost settings and making that make sense for hospitals, a continued shift to risk-based payments, and more direct contracting with self-funded employers and unions, where we can be very creative in the kinds of arrangements that we enter into. This is just a slide. This is actually on the wall of our elevator bank in our lobby, you know, where we try to lay out for our visitors who we are at Mount Sinai Morningside, and really that reflects who we are in the Mount Sinai Health System as well. And Elba, I'll conclude, and Dr. Gidwani, I'll conclude there, and I'd be happy to take any questions or any comments that anyone has.
Thank you, Mr. Gianelli, for such a eagle's eye view of how leadership or effective leadership and transformation occurs. Just, I will say that I was first introduced to the Overton window on the popular HBO show. I think it was Succession or Billions, on Billions, if you remember. He talks about the Overton window. So this was several years ago. Now, I have a couple of questions related to different areas. One, I know that, one of the first things you did when you came here was the deep dive into the whole lean methodology, Kaizen, Gemba, all this stuff. How that was a major transformational change, no? There was a major change in culture when you came to Morningside. How did you manage that transition?
Yeah, it's a really good question. It was a definite a change in culture. I would say that we managed it in a couple of ways. One, I knew enough to know that I needed a small, dedicated team to help to drive that work. So I recruited them to come with me when I came here.
I see.
And second, the initial work that we did was very participatory. So it was inclusive. It brought people from different parts of the organization together. And third, the work that we did had some tangible and concrete results. People could see that there was an effect to the work that we were doing. So much so, I'll tell you a quick funny story. I was at a dinner where with our cardiology colleagues at Mount Sinai Morningside and their counterparts at Bronx Care. And two of our cardiologists who have been with the Mount Sinai Morningside for years, they predate me by a long time. They sat with me and they said, listen, and I'm not exaggerating in the tone of the conversation, but basically it was, when you brought this lean thing in, we thought you were basically nuts. We were like, okay, but we wanted to actually sit down with you and say that you've convinced us and we're on board. And I get that kind of all the time, and I'm okay with that. And actually, I was appreciative of their candor. It takes a while, but I think the way you sort of get it to be embedded is it's got to be participatory, and lean by definition is, which is why I do think if it's not used as a cudgel, if it's not used to beat people up, and it's used to rather to lift people up, you'll get the results that you need.
Makes sense. Now, I have another question, and then I'll just open it up to everybody. Thankfully, we have plenty of time. So how do you square this circle, this perpetual tug of war between payers and providers? So the payers had a couple of great years during COVID and were not paying out that much.
Yeah.
And so let's say in the last year, Cigna is up 70% profit, Molina Healthcare 60% profit, United Health Group 28% up, Elevance Health, that what used to be Anthem and WellPoint 7% up, while the providers are now 50% or more going to have red ink on their balance sheets.
Yep.
Where does how does this square?
Yeah, I mean, it's one of the great challenges, right, in the American healthcare delivery system that you have payers that are in many respects in opposition to providers. You do have some integrated delivery systems like an Intermountain or
Kaiser,
Geisinger or Kaiser, where the insurance company is embedded. And those models, I think, are strong models because you do create alignment between the different elements of the organization. The problem in New York is because New York is so complicated with so many major academic medical centers, it would be almost impossible to replicate that model here in New York. Northwell tried and essentially got out of the business. So I think what has to happen is I think a couple of things. I think one, we have to use the market cloud that we have to try to push for changes in payer behavior. We're not impotent in the market. We're a major organization, and if we put a foot down, it's gonna have an effect. Now, will it have the entire effect that we want? No, but at least we can try to influence behavior. And then second, I think we have to find partners that we can do productive things with. So for example, the Mount Sinai Health System has a very productive relationship, direct to union relationship with 32BJ, which is the union that represents people who work in the apartment buildings.
Yeah.
So we've created very innovative products around orthopedics and bariatric surgery, where we've agreed to take less than the market would allow, and take some risk in exchange for 32BJ, working with us almost as an exclusive provider. And that's been a very successful set of programs. It's very creative, it's very innovative, and I think, to the greatest extent possible, we organizationally need to do as much of that as we can, because I think that's where the opportunities are. And if you can show that services can be provided at a lower price point and everyone wins, it's not so low that we lose money, but it's not so big that we're making more money than we should, and people are paying too much. That could be a model then for other people in the system as well.
Who else may have questions?
I do. Again, it's
Norma, you're on every call that I'm on.
well, I think this grand plan is excellent, and I think we've made tremendous progress, having been here when it was St. Luke's, and with the transformation since Mount Sinai has come. And I feel very good that you're very accessible as a person. You respond to questions and queries. But what I find, some of the problems are very ingrained at the very low levels, and it's a constant change of different personnel. We don't, we get announcements when somebody new is appointed, but not at every level, tend to be physicians or great big leadership positions, but at lower echelon, so people know where to go to get a problem solved. The other is the issue of what the patients are telling me. And this looks at the excess days, if you will, because that excess day thing is a driving financial crunch, but the patients feel they're being booted out. Mm-hmm. So it's that feeling of they're not getting something. Maybe it's how we communicate with them, I'm not sure, but that's probably part of it. But it's how to help the patient feel that they are not, in fact, being pushed or advanced too quickly, and the staff can support that, because that's what is at the ground level for the patient in terms of their experience every day. So, I mean, I hear the complaints, and I'm sure you do too, and you can't address every single one independently.
Dr. Brown, is there a question at the end of this?
That's the question of how to look at that, the ground level area, the patient experience, the staff, and getting a hold of who's in charge and how to mitigate a problem.
So I would say two things very, very, very quickly. As it relates to the first part of your question, turnover is dramatic. It's dramatic at the hospital. It's dramatic across the system, and I alluded to that in my remarks.
Exactly.
I do think we probably have. I mean, I'll be candid. I think we probably have to do a better job of refreshing, people's knowledge of who's where. simply because of the amount of turnover that is occurring. And there's turnover that's unintended, and then there's just changes that are going on corporately, and we're grappling with both. So I think it's a fair observation that we probably have to do more on the communication front to just update everyone on all of the changes that are occurring.
Yeah.
As it relates to your second question, I honestly think that the key there, and this gets into the weeds a bit, so I'm just going to be brief, but I think the key there is that the physicians that are attending to the patient who's been admitted need to begin early, and the nurses do too, socializing the potential day of discharge for the patient. I think it's important that conversation occur every day. And obviously the day of discharge can change, but I think we need to set the expectation that that's the goal. The goal is, for you to go home. And I think the best way to do that is to start that conversation literally upon admission. Because you're right, if it's not something that's happening every day and all of a sudden it's like, okay, you're ready to go, that becomes scary for somebody who's been in the hospital for a while and now has to get used to how they can live on their own. So I think it's the early socialization of the need to be discharged and to go at the appropriate time safely. I think is what I think would help, and I think what's required.
Thank you so much for that, Mr. Ginelli. It's almost 2:00 on the dot. I thank everyone for attending. You have had one of the largest audiences in recent memory for the Grand Rounds, Mr. Ginelli. It's such a pleasure, and we'll have you back before the next pandemic.
Okay, that would be great. And Dr. Gidwani, if there are any questions that folks have, I see that there was some chat.
Yeah.
If anybody has any questions that I didn't get to, please send them, and I can try to answer them. And I will make the PowerPoint presentation available to everyone who attended.
Certainly. Thank you so very much. We're on for our next meeting, Critical Care Committee meeting, led by Dr. Kohli.
All right.
Thanks, Art. Bye now.
Thank you. Thank you, guys. Thank you so much.